Hello everyone, my name is Aditya Ananta Fegde. I am from DUPMC Jalgaon. Today we are going to talk about oral anti-diabetic drugs. So how can you manage diabetes? Either you can facilitate the secretion of insulin, or you can decrease the resistance of insulin resistance, or you can directly hinder the absorption of carbohydrates from your gut. So these are the first two classes, sulfonylureas and meglitimide. These are ATP sensitive potassium channel blockers. So next, talking about sulfonylureas, they act by binding to the SUR1 receptor located on beta cell membrane. They enhance insulin secretion, and these drugs only augment second phase of insulin secretion. And hepatic degradation of insulin is also reduced by these drugs. Nowadays, we only use second generation sulfonylureas, and after prolonged use, downregulation of the receptors occur. Next, we will see about pharmacokinetics. These drugs are well orally absorbed and 90% or more plasma protein bound. These drugs have low volume of distribution. Next, we will see about drug interaction. Now, the enhancing sulfonylurea action are phenylbutazone. This drug displays from protein binding. Second is cimetidine and ketoconazole. These drugs inhibit the metabolism, and salicylates and propranolol synergize the action of sulfonylureas. Now, talking about the drugs which decrease action of sulfonylureas are phenytoin and rifampicin. These drugs induce metabolism, and thiazide and furosemide. These drugs suppress the insulin release. Next, talking about adverse effect, they have hypersensitivity, hypoglycemia, weight gain, nausea, and vomiting. The drugs coming under the heading of sulfonylureas are tolbutamide. This is the only first gen drug. Now talking about second generation, there are glipizide, glidazide, glimepiride, and clibeneclamide. Next class of drug are D-phenylalanine analogs. These drugs are ATP sensitive potassium channel blocker with quick and short lasting insulinemic action. These drugs limit postprandial hyperglycemia in type 2 diabetes without producing late phase hypoglycemia. These drugs are quickly absorbed and rapidly metabolized. Side effects are mild, mild headache, dyspepsia, arthalgia, and weight gain. Next, talking about the mechanism of action of ripaglinide. These drugs bind to sulfonylurea receptor and cause closure of ATP sensitive potassium channel. This causes depolarization of cell membrane, which result in release of insulin. Ripaglinide, this drug is quickly absorbed and rapidly metabolized. Side effects are mild headache, dyspepsia, arthalgia, and weight gain. These drugs are indicated only in selected type 2 diabetes mellitus who suffer pronouncedly from postprandial hyperglycemia. This drug should be avoided in case of liver diseases. Now, talking about nataglinide, this drug stimulates the first phase insulin secretion by closing beta cell of ATP sensitive potassium channels. This drug is faster onset and shorter lasting, used only in type 2 diabetes mellitus along with other antidiabetics to control postprandial rise in blood glucose. Side effects are dizziness, nausea, flu-like symptom, and joint pain. Next, talking about biguanides, the metformin. This drug is most commonly used oral antidiabetic. Now, this drug does not stimulate pancreatic beta cells and improve lipid profile in type 2 diabetics. Now, talking about mode of action, recent studies have recognized the activation of AMP dependent protein kinase to play a crucial role in mediating the action of metformin. Key features of metformin are suppression of hepatic gluconeogenesis and glucose output from liver. This is the major action responsible for lowering blood glucose. This drug also enhances the insulin-mediated glucose uptake and disposal in skeletal muscle and fat. So basically, what does this drug do? This take the glucose out from blood and put it into muscle and fat cells. This drug interfere with mitochondrial respiratory chain and promote peripheral glucose utilization. Now talking about pharmacodynamics, metformin is well absorbed orally and not metabolized, but excreted unchanged by kidney. Clearance of metformin is approximate to GFR. Due to this, it accumulates in renal failure and increase the risk of lactic acidosis. Now, talking about side effect of metformin, there are abdominal pain, anorexia, bloating, nausea, mild diarrhea, and tiredness. And toxicity causes metallic taste in tongue. Metformin is contraindicated in renal insufficiency. Drug like cimetidine furosemide may compete with metformin for excretion, increasing the chances of toxicity. Now, uses of metformin are it is a anti-hyperglycemic but not hypoglycemic. It promote weight loss. It has potential to prevent macrovascular as well as microvascular complication of diabetes. No acceleration of beta exhaustion and failure in type 2 DM. Anti-hyperglycemic efficacy is equivalent to other oral drug. It can be combined with other oral or injectable antidiabetic. Can prevent on onset of type 2 DM in obese and middle-aged subject with impaired glucose tolerance. Now, this is a new class of drug, thiazolinidones. Only one thiazolinidone, which is a pioglitazone, is currently available in India. Rosiglitazone, the other member, is banned. Selective agonist for nuclear peroxisomal proliferative activating receptor gamma. Pioglitazone inhibits the transcription of several insulin-responsive genes and tend to reverse the insulin resistance by enhancing GLUT4 expression. Entry of glucose into fat and muscle cells is also improved. Now, talking about pharmacodynamics, pioglitazone is metabolized by both CYP2C8 and CYP3A4 receptors. CYP3A4 isoenzymes. Now, ketoconazole inhibit and rifampicin induce its metabolism. Pioglitazone is indicated in type 2 diabetes mellitus but not in type 1 diabetes mellitus. Adverse effects are plasma volume expansion, edema, weight gain, headache, myalgia, and mild anemia. Now, coming to uses, it is indicated only in type 2 diabetes. It reduces blood glucose and HbA1c without increasing circulating insulin. About 25 patients may not respond to the medication due to low baseline insulin level. It should be stopped if HbA1c reduction is less than 0.5% at 6 months. Pioglitazone is primarily used to supplement sulfonylurea or metformin, and in case of insulin resistance, however, it is not likely to be effective when beta cell failure has set in. Now, talking about the last class of drug, alpha glucosidase inhibitors. The first one is acarabose. It is a complex oligosaccharide which reversibly inhibit alpha glucosidase, the final enzyme for the digestion of carbohydrate. So as you can see, the final enzyme for digestion is inhibited. So the absorption and digestion of carbohydrate does not take place. GLP-1 release is also promoted, which may contribute to the effect of acarabose. Patient acceptability of alpha glucosidase inhibitors is poor due to uncomfortable GI symptoms such as constipation. Hepatic transaminase may also rise in during administration of this drug. Uses are it may be used as an adjuvant to diet in obese diabetics. Acarabose 50 to 100 milligram twice a day is taken at beginning of each major meal. Regular use lower the HbA1c modestly. Long-term acarabose treatment in pre-diabetic reduce the occurrence of type 2 DM. Now, miglitol and voglibose are the other alpha glucosidase inhibitor. Now, talking about miglitol, it is a smaller molecule than acarabose and stronger inhibitor of sucrase. Absorption of miglitol is substantial but variable. The absorption drug is excreted by kidney and systematic toxicity of miglitol is known. Now coming to the status of oral antidiabetic in diabetes mellitus. So cardiovascular mortality is higher in patient with biguanides and sulfonylurea prescription than those treated with only with diet and exercise and not with any other medication. Insulin and sulfonylureas reduce the microvascular complication such as retinopathy, neuropathy, or nephropathy. Now metformin could reduce both microvascular as well as macrovascular complication. Now there is a strict guideline for use of oral anti-diabetic drug, and they are indicated only in type 2 diabetes in addition to diet and exercise. So these drugs are most effective in patients with following condition. The patient should be above 40 age on onset of this disease, obesity at the time of presentation, and the duration of disease should be less than 5 years. The fasting blood sugar should be less than 200 milligram per dl, and insulin requirement should be less than 40 unit per day. And there should be no history of any type of ketoacidosis or any other complication. Now talking about glucagon, this is a single chain polypeptide containing 29 amino acid and having molecular weight of 3500. This is secreted by the Langerhans and commercially produced by recombinant DNA technology. The secretion is also regulated by glucose level, paracrine hormones, and nervous system. Now, talking about mode of action, it activates adenylyl cyclase and increase cyclic AMP in liver, fat cell, heart, and other tissues. Most of its actions are mediated through this cyclic nucleotide. Now, glucagon is used in case of hypoglycemia as it increase the level of blood glucose, so it is used in hypoglycemia. Now, as you can see this table, this is the indication for usage of oral anti-diabetic drug. Now, if the diabetes is of type 1, then diet along with insulin is prescribed and the disease should be in control. Now, in case of type 2 diabetes, diet plus exercise and metformin is used. If the disease is uncontrolled and the patient is well nourished or obese, then metformin plus one drug, which may be sulfonylurea, meglitimide, or DPP-4 inhibitor may be used. And even if the disease is uncontrolled, then metformin is used along with two drugs, which may be sulfonylurea or meglitimide or DPP-4 inhibitor plus pioglitazone. And even if the disease is uncontrolled, then insulin is also added in the medication. And if the patient is severely underweighted or have any other complications such as pregnancy, infection, or have undergone any surgery, then insulin plus metformin is sufficient. Now coming to the MCQs, which of the following is not a sulfonylurea? So the correct answer for this question is metformin, option C. Now coming to next MCQ, which class of oral antidiabetic drug is associated with lactic acidosis? The correct answer is meglitinide. Now coming to third MCQ, what is the mechanism of action of oral antidiabetic drug? The action here is a reduction of insulin resistance. The other two mechanisms are reduction in insulin resistance, this is done, then retardation of carbohydrate absorption and facilitation of insulin release. Now coming to next MCQ, which class of oral antidiabetic drug is associated with hypoglycemia? The answer is sulfonylurea. Then last MCQ, which class of oral antidiabetic drug is associated with weight gain? Correct answer is DPP-4 inhibitor. So I conclude my presentation here. Thank you for listening to me.